Imagine you're a detective, but your crime scene isn't some smoky back room. It's the human neck. You've got a suspect, this lump that's just appeared, and you have maybe 10 minutes to figure out if it's harmless or if it's a killer. And the catch is, you have to solve like 80% of the case before you even lay a hand on the patient or order a single scan.
That is the high stakes world of a thyroid clinic. It really is. It's pure detective work. And what we're digging into today is this really fascinating breakdown of how an expert does that.
Yeah, we're doing a deep dive into what is basically a masterclass in clinical reasoning.
Right.
We're looking at these guidelines that contrast, the wrong way, the way a novice might do it, with the right way, which is this expert surgical level assessment. And the difference isn't just about being polite, it's about life and death accuracy.
Absolutely. The sources we're looking at, they basically say a novice treats this like they're filling out a form. Just ticking boxes. Name, check. Age, check. But the expert, the FRCS level surgeon, they use every single question like a surgical tool. They're cutting away possibilities with every single answer.
That is what I want to get into, that jump from just, gathering data to actual pattern recognition. Because I'll be honest, when I read the wrong way examples, I kind of felt a little attacked. They sound like perfectly normal questions to me.
Well, they do, and that's the point. It's all about the intent behind the question.
Yeah.
If you ask something without knowing exactly how the answer changes your diagnosis, you're just wasting time. And in this field, time and precision are everything.
Okay, so let's start with the consultation starts. The first impression, biodata. The novice just asks, how old are you, and writes it down. Why isn't that enough?
Because the number itself is kind of meaningless unless you are immediately applying a risk filter to it. In thyroid pathology, age is one of the biggest stratifiers we have. The source outlines this really specific red flag zone. This is the U shape of risk, right? I remember reading about that. Precisely. Yeah, think of a U curve. So if your patient is in the middle of that U, say between 20 and 60, a lump is statistically more likely to be benign. It's common. But if you are at the extremes, under 20 or over 70, the alarm bell should be going off loudly.
Okay, wait, let's pause on under 20. I always think of cancer risk as something that goes up with age. Why is a teenager with a lump a red flag?
That's the trap. In kids and teenagers, normal thyroid nodules are actually really rare. The gland just shouldn't be lumpy at that age. So if a child does have a solitary lump, the statistical chance of it being malignant, specifically papillary carcinoma, is way, way higher. It's an anomaly.
That makes sense. Rare things shouldn't happen, so if they do, you really need to pay attention. And what about the other end? Patient over 70.
Then you're in the danger zone for something called anaplastic carcinoma.
That name alone sounds bad.
Bad is an understatement. Anaplastic is one of the most aggressive, lethal cancers that exists, period. It goes unbelievably fast. So just by knowing the age, the expert has already adjusted their suspicion. A 15-year-old and a 75-year-old are, they're already on high alert.
And the other big demographic the guide focuses on is sex. This one surprised me, that being male is a huge risk factor.
It's a little counterintuitive, isn't it? Because thyroid problems in general are overwhelmingly female. Goiters, benign nodules. They are much more common in women. But that commonality actually dilutes the cancer risk. If a woman comes in with a nodule, odds are it's benign.
It's the whole needle in a haystack thing.
Exactly. But if a man walks in, men just don't get thyroid nodules that often. So if a male patient has a single lump, the source says the malignancy risk is 2 to 3 times higher than for a woman.
So a 75-year-old man walking in is a totally different starting point from a 30-year-old woman.
A completely different universe of risk. And look, we haven't even asked about the lump yet. We're just looking at who's in the chair.
Let's talk about occupation. The guide lists it as a critical early question. I'm guessing it's not just to make small talk.
No, and this is where the novice misses the point. They ask, what do you do to be polite? The expert asks for 2 reasons, causation and consequence. Causation is rare. Do they work in a nuclear plant? Probably not. But consequence, that's huge.
It is about the voice, isn't it?
It is. Thyroid surgery happens millimeters away from the nerves that control your vocal cords. If your patient is a professional singer, a teacher, a lawyer, even a slight change in their voice could end their career.
That's a heavy responsibility.
It is. And knowing that upfront changes the whole conversation about risk, you might be a bit more conservative with a singer than with, say, a retired accountant. You have to treat the whole person, not just the lump.
Okay, so we've profiled the patient, now we interrogate the suspect, the lump. The source calls this local analysis.
And this is where the descriptions get really good. So the novice asks, how big is it? And where is it?
Which seems pretty logical, to be fair.
It is logical, but it's low resolution information. It's static. The expert wants the story, the trajectory. How big is it now and how big was it a month ago? The rate of growth. That is the single most important piece of data you can get.
So what's the timeline we should be worried about?
Well, most standard thyroid cancers like papillary are actually pretty lazy. They grow over months, even years. A patient might say, oh, I noticed this 6 months ago and it's a little bigger. That's concerning, sure, but it fits a standard profile.
But if they say weeks?
If a lump doubles in size in 3 weeks, you are in crisis mode. It's usually one of 2 things. Either it's a hemorrhage, a bleed into a cyst, which is benign, or it's anaplastic carcinoma. That's the tumor's biology just running wild.
The guide has these really vivid analogies for how the lump feels. I love this. It calls it the face test.
I love this too. It's a classic teaching tool because everyone has their own face for reference. It standardizes the sense of touch.
Okay, walk us through it. Listeners, you can actually do this right now.
Okay, so if you feel the lump and it's soft, sort of fluctuating,
Yeah.
like your cheek when you puff it out,
Puffs, cheek. Okay, right, squishy.
that suggests a cyst. Fluid-filled, usually benign. Now, if it feels firm, a bit rubbery, like the tip of your nose or your chin,
Firm, but with some give.
that's more like typical thyroid tissue, a goiter or a benign nodule. Solid, but not hard.
And the really bad one, the red flag.
The forehead, press on your forehead. It feels like bone, right? There's zero give. If a thyroid lump feels rock hard or bony, that is malignancy until proven otherwise. Normal tissue should not feel like stone.
Cheek, chin, forehead. That is so memorable. I am definitely gonna be checking my neck for forehead lumps after this.
Just don't press too hard. But yes, hard as bone is the big danger sign.
Okay, now there's this physical test that the guide says is the absolute hallmark of a thyroid exam, the swallow test. Why is it so important to watch someone drink water?
It all comes down to anatomy. The thyroid gland it's wrapped in this sheath that's tethered directly to your larynx, to your voice box.
So they're physically connected, like a trailer hitched to a car.
Perfect analogy. When you swallow, your larynx has to move up to close off your airway. And because the thyroid is strapped to it, it has to go along for the ride. It has no choice.
So if the lump moves up when they swallow.
It confirms the lump is actually part of the thyroid. If you have a neck lump that doesn't move with a swallow, it's probably something else, a lymph node, a cyst, something separate. It's the fastest way to know you're even looking at the right organ.
But there's a sinister twist to this, right? The guide talks about fixity.
Yes, and this is the FRCS level detail. If a lump is clearly in the thyroid, but it stays dead still when the patient swallows, that's a very, very bad sign
Why wouldn't it move?
because it's stuck. It means a cancer has likely broken out of the thyroid capsule and has invaded the surrounding muscles or the trachea. We call that T4 disease. The tumor has literally anchored itself to the neck.
Wow. So no movement isn't just a weird quirk, it's a sign of advanced invasion.
Correct. And it changes the whole game. The surgery goes from, let's take out the gland, to, we might have to reconstruct the neck. It's a massive escalation.
That leads perfectly into the idea of pain. I think most people assume that if a lump hurts, that's the worst case scenario. It hurts, so it must be cancer.
And that's one of the biggest myths we have to bust. In the thyroid, the rule of thumb is actually the opposite. Most thyroid cancers are painless. They're sneaky. They just sit there quietly for years.
So pain is good news.
Relatively speaking, yeah.
Yeah.
Pain usually means inflammation or rapid stretching. So if it hurts, it's often a cyst that's bled into itself, which hurts a lot. Or something called subacute thyroiditis, which is a viral inflammation.
It's almost a relief if the patient says it's killing them.
It often lets the surgeon take a breath, unless, of course, it's that rapidly growing anaplastic cancer we keep mentioning. That could hurt because it's just destroying everything in its path. But generally, silent lumps are the suspicious ones.
Let's talk about the silent symptoms that actually scream danger. The guide has a whole section on red flags, and it calls one question the single most important question you can ask.
Hoarseness.
Has your voice changed?
If you take away only one thing from this whole deep dive, it should be this. A thyroid lump plus a hoarse voice equals nerve paralysis until you prove it isn't.
Explain why. What's happening there?
The recurrent laryngeal nerve, which powers your vocal cord, runs in a little groove right behind the thyroid gland. If a cancer grows out of the back of the thyroid, it can invade that nerve, squeeze it, and just shut it down.
And the vocal cord is paralyzed.
Exactly. And benign nodules almost never do that. They might push the nerve, but they don't invade it. So if the nerve isn't working, it means the lump is attacking it. The probability of cancer just shoots up to over 90%.
90%. That's a staggering number. And the guide says this changes everything immediately.
It mandates that you look. You cannot take that patient to surgery without doing a laryngoscopy, putting a small camera down their throat to see the vocal cords. You have to know if that nerve is working. Because if you don't, and you accidentally damage the other nerve during surgery, the patient can't breathe.
Unbelievably high stakes. Speaking of breathing, there's a physical test in the guide called Pemberton's sign. It almost sounds like a magic trick. You ask the patient to raise their arms.
It's one of the most dramatic things you can see in a clinic. It's a test for a retrosternal goiter. That's when the thyroid is so big, it grows down into the chest because there's no more room in the neck.
So it's hiding behind the breastbone.
Right. And the top of the chest, the thoracic inlet, is very crowded real estate. You've got your trachea, esophagus, major blood vessels all squeezing through.
And then you should have a giant thyroid in there too.
Exactly. So when you ask the patient to raise their arms up over their head, that motion pulls the whole thyroid further into that bottleneck. It's like corking a wine bottle.
And what happens?
It squishes the superior vena cava, the main vein bringing blood back from your head. So the blood gets trapped.
That sounds like something you would definitely notice.
Well, you do. Within a minute, the patient's face turns bright red. The veins in their neck bulge out. They might get dizzy, feel short of breath. That is a positive Pemberton sign.
Just from lifting their arms. That's incredible. It tells you there's a huge mass in the chest without even needing a CT scan.
It's just bedside physics. You're using anatomy to reveal the pathology.
Okay, so we've covered the lump itself, but the thyroid runs the whole body's metabolism. The source calls this systemic detective work.
Right. This is where you screen for function. Is the gland overactive hyper or underactive hypo?
I think most people know the basics. Hyper is fast, hypo is slow. But the guide had this really interesting point about weight.
The weight question is a key differentiator. With hyperthyroidism, your metabolic engine is just screaming. You're burning calories like crazy, so you lose weight. But, and this is the absolute key, your appetite goes through the roof.
So they're eating everything in sight but still getting thinner.
Exactly. Now compare that to cancer cachexia, where people lose weight because they feel sick and have no appetite. That hungry skeleton look is classic for an overactive thyroid.
And what about for hypothyroidism, the slow engine?
Everything slows down. Constipation, feeling cold all the time, mental fog. But listen to the voice again.
Wait, I thought a hoarse voice was nerve invasion.
This is a different kind of voice change. In severe hypothyroidism, the vocal cords themselves get swollen with fluid. It's called myxedema. The voice becomes deep, coarse, and sort of sluggish. It's not the weak, breathy voice of a paralyzed nerve, it's a thick voice.
That's such a fine distinction, breathy versus thick.
But it tells you a completely different story. One is mechanical problem invasion. The other is a metabolic problem failure.
Let's go back in time now, the hidden history. The guide mentions a time bomb that could have been planted decades ago.
Radiation. This is so important. The thyroid gland is uniquely sensitive to radiation, especially in children.
And the delay is really long, right? We're not talking about something that happened last week.
No, we're talking 10, 20, even 30 years ago. The classic example is someone who had radiation for lymphoma as a kid. Or, historically, doctors used to give radiation for benign things, like acne or enlarged tonsils.
They radiated tonsils, seriously.
Decades ago, yes. It sounds crazy to us now, but that exposure increases the risk of papillary thyroid cancer by something like 30-fold. So asking, did you ever have medical treatments as a child, is hunting for a cause that's been dormant for years.
The other part of that history is genetics, family. The guide warns you not to just ask any thyroid problems in the family.
Because that's too vague. Thyroid problems could just mean their aunt takes a pill for an underactive thyroid. That's common, and not what we're looking for. We're hunting for specific genetic syndromes, mainly MNN2.
Multiple endocrine neoplasia.
Correct. It's a genetic condition that causes medullary thyroid cancer. But it doesn't just hit the thyroid, it hits other glands too. So the expert asks these seemingly random questions like, anyone in your family have kidney stones? Or high blood pressure at a really young age?
Connect those dots for us. Why kidney stones?
Kidney stones can come from overactive parathyroid gland, which causes high calcium. And the high blood pressure can come from a tumor on the adrenal gland called pheochromocytoma.
So if your patient has a thyroid lump, and then they mention their brother had kidney stones and adrenal surgery,
You stop everything. You're not just dealing with a lump anymore, you're almost certainly dealing with a major genetic syndrome. And that changes the surgery because you have to test their family. It changes everything.
that is real detective work. Diagnosing a genetic condition from an uncle's kidney stone.
That's that synthesis we talked about at the beginning. You're not just looking at the neck, you're looking at the whole family tree.
Which brings us to the climax of the whole consultation. The source uses this phrase, kia kia.
Yeah, it's a great phrase. It's Hindi for basically what have you done? Or what's the summary? It's that moment where you pull all the threads together.
It's a big reveal.
Exactly. The guide really stresses that before you even order an ultrasound, you should have a differential diagnosis in your head. You should be able to say, okay, based on the age, the rapid growth, and this rock hard feel, I am very worried about malignancy. Or based on the pain and the fever, this is almost certainly thyroiditis.
You don't order tests to find the answer. You order them to confirm what you already suspect.
That's the expert mindset. If you don't know what you're looking for, test results can just confuse you. The order is strict. Blood test first, the TSH to check function, then an ultrasound to look at the structure. And only then, if you need to, do you bring out the needle,
The biopsy.
the fine needle aspiration, or FNA. That's how you get cells. But you only do it if the story and the ultrasound are pointing you in that direction. You don't biopsy every single lump.
So we're near the end, but the source lists some final pitfalls, and these seem to be more about communication and managing fear.
The biggest one is about language. You must never ever say to a patient you have cancer based only on your exam.
Even if it feels like bone, even if they're hoarse.
Even then, you can say this has suspicious features, you can say I'm concerned, but you deal in probabilities, not certainties, until you have that pathology report. Because if you're wrong, and even experts can be wrong, you've just caused unbelievable trauma for nothing.
And the flip side of
The
that.
flip side is never ever dismissing a red flag. Never tell a patient with a lump that their hoarse voice is just a cold. That's how you miss a cancer.
It sounds like this constant balance between extreme caution and, aggressive curiosity.
That's a perfect way to put it. You have to be paranoid on the patient's behalf.
So if we zoom all the way out, what's the big takeaway here?
I think the takeaway is that the body tells you the story if you just know what questions to ask and how to listen. The novice hears lump. The expert hears rapid growth in a 75-year-old male with a fixed mass and sees all the flashing red lights.
It's about not taking a single piece of data for granted.
Clinical reasoning isn't magic. It's just high-stakes pattern recognition. It's connecting arm raising to chest compression. It's connecting kidney stones to thyroid genes. It is just rigorous logical deduction.
And it really proves that sometimes the most advanced tool in the room isn't the MRI scanner, it's just a well-phrased question.
And a glass of water.
And a glass of water. That's all for this deep dive. Thanks so much for listening. Go check your neck gently, please, and we will catch you on the next one.